Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry's Foundation. Today's episode is brought to you by the Anterior Segment Disease Care Channel. Today's title is A Pilot Study of Low-Dose Doxycycline to Lower IOP in Patients with Glaucoma and Ocular Surface Disease. I'd like to thank our host, Dr. Tom Quinn, our topical editor, Dr. Kelsy Steele, and our topical expert, Dr. Dominick Opitz. And now it's my pleasure to begin today's broadcast.
Greeting you of curious minds to the American Academy of Optometry's clinical podcast series. In this episode, we're going to be discussing a poster that explored the possible relationship between doxycycline and intraocular pressure. I'm Dr. Tom Quinn, and our guest expert for this episode is Dr. Dominick Opitz, who's a practitioner and associate professor at the Illinois College of Optometry and one of the authors of the poster that we're going to be discussing today. Welcome, Dr. Opitz.
Hey, Tom, thank you very much for having me. This is super exciting. I'm glad to have the opportunity to kind of share the work that myself and my colleagues have done here.
Nick, this is exciting for us because every podcast we've done up to this point has been on a published paper. So you're our first poster that we're going to be discussing. So yeah. And the poster was presented at the annual meeting of the American Academy of Optometry in San Diego. And you were one of the authors. The lead author was Dr. Catherine Haas.
Haas.
Okay, yes. Thank you. And let's start with specifically, what is it you guys wanted to study?
Well, like a lot of research, things just kind of happen almost by accident and through just some clinical observations that, I personally have had over the years managing glaucoma. And, one of those observations is that, many of my patients have ocular surface disease that have glaucoma. And there's been several patients over the years where their ocular surface disease was so pronounced that we actually had to take, a holiday from the medications that they were taking to kind of clear up the ocular surface. And interestingly enough, when I would do that, and then I would sequentially add back medication, the pressure actually was better than when they were on, 3 or 4 different medications.
Okay. So the population you were looking for here then had to be under treatment for mild to moderate glaucoma and had to have ocular surface disease, right? Or signs or symptoms of ocular surface disease. What signs and symptoms did your subjects display?
So from a symptom standpoint, the common symptoms that are oftentimes associated with dry eye, redness, irritation, burning, just general ocular discomfort, is what most patients would oftentimes complain of. And from a clinical signs perspective, most commonly we saw, almost everyone had signs of some form of meibomian gland dysfunction.
Okay.
And then there was oftentimes associated decreased tear breakup time. There was staining to the cornea and to the conjunctiva as well.
Okay, so you didn't break them out specifically as I call it quality versus quantity dry eye. So quality where they have meibomian gland dysfunction versus quantity where they just don't produce much tear. Was it a mismatch of those kinds of folks?
Yes, it was very much a mixed match. For the initial pilot study that we did, enrolled 6 patients. That's what we kind of reported on in this last poster that we presented. And about 2/3 of them had, clinical signs of meibomian gland dysfunction. And then the remaining had just, poor tear quality, rapid tear breakup time, and so on.
Okay. I noticed that there were 6 subjects and 6 authors. So I'm curious, was one subject seen in each of the authors' offices, or how did that work?
Yeah, no. So the patients were being in an academic institution. We include students and residents in on the whole research project, and many of the authors that were listed are some of my students, many of which have matriculated on to doing great things on their own. But myself and Dr. Haas were the primary investigators for the data collecting.
Okay.
And then our co-investigators would participate in identifying suitable candidates, reaching out to them and doing a lot of the, behind the scenes, because there's a lot of work that goes into good quality research, as I'm sure you're well aware of.
Yeah. Okay. So what'd you guys find?
Yeah. It was interesting. This was actually a takeoff from a poster that Milton and I presented Milton Hom a couple of years ago. And that poster showed a significant drop in IOP, more than a 30% decrease in IOP. This was, a patient that had bad ocular surface disease. We treated them with doxycycline. The IOP went down. We took them off of the doxy. The IOP went back up. We put them back on the doxy, and the IOP went back down. So that caused us to stop and think, all right, is this a one-off? Or is there something to this, using the doxycycline? So the raw data, so baseline mean IOP for the 6 subjects that we enrolled was 16, okay? And, patients were treated with doxycycline for 3 months, and then we checked the IOP at 1 month. We checked it again at 3 months. And then at 3 months, they stopped the doxycycline, and then we rechecked their IOP at 6 months. So 3 months post doxycycline. And interestingly enough, at 1 month, the IOP reduced from baseline by more than 8% of an IOP reduction. And then at 3 months, the IOP went down by a total of almost 15.5% decrease from their baseline IOP.
Did you check that for statistical significance, Nick?
We did, and statistically, we wouldn't have reported on it if it wasn't statistically significant. And much to our surprise, as you would expect, it was statistically significant.
Okay.
So, p-value. Yeah. So I don't know if you want the actual p-values, but
I just wanted to make sure the audience knew that you looked at that. So.
Yes.
And just to be clear, the doxycycline, the dosage, tell us what you did.
Yes. So this was low dose doxycycline. So we use 50 milligrams once a day. And, in a low dose, doxycycline has been shown to have some anti-inflammatory properties, more so than the antimicrobial properties, like we do with higher dose, typically like, 100 milligrams twice a day. So this was 50 milligrams once a day.
Great. So what do you think's going on here?
There's a lot. I mean, I don't have a short answer for you.
Okay.
Based on, previous work that has been published, it's interesting that BAK, there was one case series that was published, and this looked at a case series of patients who were referred to a tertiary eye care clinic with the intent of having invasive glaucoma surgery. And, the surgeons decided that the ocular surface was just too roughed up to proceed with surgery, because a poor ocular surface can lead to, failure with invasive glaucoma surgery. So this author took patients and changed all their medications when they could to preservative-free medications, and then added doxycycline. What we did is we kept the medications the same. We did not change their medications. We just added in doxycycline.
Got it.
So I feel, and there's been some reports that BAK, it has not only the ability to penetrate the ocular surface, the conjunctiva and then the cornea, but it can and does enter into the anterior chamber. And, if you think about it anatomically, the cornea, the peripheral cornea, it's just adjacent to the trabecular meshwork. I mean, it's less than 1 millimeter away from the exterior surface of the cornea. So it's been shown that when you add BAK, even without glaucoma medications, just straight BAK to the cornea, it does enter into the cornea and it gets into the trabecular meshwork. And when it gets into the trabecular meshwork, it causes a whole host of different biological changes that take place. And one of the underlying common threads associated with many of the changes to the trabecular meshwork, so the human trabecular meshwork cells, is you get an inflammatory response that takes place. And these inflammatory responses with straight BAK causes structural changes to the trabecular meshwork that mimics the structural changes that we see in patients that have open angle glaucoma.
Wow.
So, MMPs, we know that the MMP, specifically MMP9, has been found to be, very detrimental from an inflammatory standpoint to the trabecular meshwork.
Yeah.
And so my hypothesis or my theory is that, low dose doxy, being an anti-inflammatory agent, is somehow reducing the inflammatory response that's taking place within the trabecular meshwork. And by doing that, you're allowing the extracellular matrix to kind of turn over, which oftentimes gunks up the TM, which is why patients with open angle glaucoma have resistance to outflow. So it must be something with the anti-inflammatory response that is taking place.
Interesting stuff. Thank you so much, Dr. Opitz, for sharing the results of your early studies, and we're looking forward to seeing what develops over time. We appreciate your expertise, and thank you all for listening.
Thank you.
And a special thanks to CooperVision for their educational grant to make it all happen.